The Honorable Court Judge Shauna Strickland is about to enter the courtroom. Hear ye, hear ye. All those with business before this court, draw near and be heard. The state of health care versus the profession of respiratory care, docket number 01CR01237 is about to begin. You may be seated.
Is the state ready?
Your Honor, the state is ready.
Is the defendant ready?
We are, Your Honor.
Ladies and gentlemen of the jury, each of you has been sworn to your oath to try this case fairly. The trial will begin with opening statements by the lawyers as to what they expect the evidence to be. At the close of the evidence, the lawyers may make arguments on behalf of their clients. Neither what is said in the opening statements nor in closing arguments is to be considered proof of a fact. However, if the lawyer admits some fact on behalf of his or her client, the other is relieved of the responsibility of proving that fact. After the opening statements, the plaintiff will introduce the evidence. After that, the defendants may introduce evidence, and there may be rebuttal evidence. While the trial is in progress, I may be called upon to determine questions of law and to determine whether matters may be considered by you under the law. No ruling or remark I may make at any time during the trial will be intended or should be considered by you to indicate my opinion of the facts. You are the sole judge of the facts in this case. After all of the evidence has been presented and you have received my final instructions and heard the closing arguments of the lawyers, you will retire to the jury room for your deliberations.
Your Honor, I have an objection at this point. Look out there. These are respiratory therapists and educators in this group. They have a bias and a prejudice in favor of the profession. I don't believe they can be fair fact-finding.
Your Honor, these people are the cognoscenti of their profession. They're clinicians, managers, educators, researchers. They believe in evidence-based medicine. They want nothing but the best for this profession, even if that means finding guilt with my clients. They can try this case fairly and objectively.
Well, they better, because their professional lives may depend upon it. I'll take Mr. DeWitt's objection under advisement, but for now, let's move on to opening arguments. Mr. DeWitt, the floor is yours.
Thank you, Your Honor. I apologize, my microphone has slipped there. Ladies and gentlemen, I represent the state, and I must prove beyond a reasonable doubt that the respiratory therapy profession, represented by the accused, who stands indicted for negligence, mismanagement, and unprofessional conduct, is guilty of those offenses. The witnesses who come before you today, Steve Nelson, Carl Hinkson, and Tom Lampere, have ignored opportunities to further their profession. They have steadfastly stuck to what worked 20 years ago, but which is now no longer practical or useful. We will show, through our experts, that there is harm befalling the patients, the public, and ultimately the employers of the accused. The evidence will show that Steve only started one new program in the past 15 years, pulmonary rehabilitation, and it failed for lack of reimbursement. We'll also illustrate that Carl, once a talented, passionate, and well-intentioned RT, is now just going along to get along, content for the way respiratory therapy is practiced under the old guard. And finally, and perhaps most notably, we'll show that Mr. Lamphere, the teacher, the mentor, the mensch to these young students, has failed in his ability to cultivate competent, educated therapists who enter the workforce. We will show that they are generally unaware of the opportunities that present under the Affordable Care Act, and that their head is so far stuck in the sand that it may be too late to save them. We will ask you to convict Mr. Nelson, Mr. Hinkson, and Mr. Lamphere, collectively referred to as the profession, for dereliction of duty. Your Honor.
Ms. Milligan.
Your Honor, the state has no case. Not every hospital is the Mayo Clinic. Not every doctor delivers care on the cutting edge of medical science. Whether a doctor uses Keflex or Ancept is a clinical decision that the doctor gets to make. There's no reason a therapist should be making doctors' decisions. They're not equipped for that. The evidence will be that the therapists at Our Lady of Perpetual Billing love their boss. They enjoy a good standard of care. They have good jobs that pay well. And while they may work hard, they care for their patients. We'll also show that the education system at Gotham City University complies with accreditation standards and is in no way a hindrance or poor representation of the field. We will ask you to acquit. If the facts don't fit, you must acquit. The profession, my clients, are so sure they are innocent that against my advice, they are taking the stand to tell you in their own words why they should not be pilloried for just doing their job.
Thank you, Ms. Milligan. In an effort to provide expeditious resolution of this case, I am hereby authorizing Mr. Galvin to swear in all of our witnesses at once. Mr. Galvin.
All witnesses stand. Raise your right hand. Do you promise to tell the truth, the whole truth, and nothing but the truth, so help you God? Be seated.
Mr. DeWitt, call your first witness.
Your Honor, the state calls Steve Nelson to the stand. Steve, can you please state your name for the record?
Steve Nelson.
How long have you been managing a department?
About 20 years.
How many protocols do you have in place?
Those protocols are just like for teaching hospitals, and they're the way that the residents work with the RTs so they know what they're supposed to be doing. They don't apply to our size hospital at all.
Well, how do you measure the success of your department?
We have the best productivity in our national compare group. We do more therapy and charge more treatments and get more done than any other department. Our productivity numbers are terrific, and my boss loves me. You know you're doing right when nobody's asking any questions.
How many nebulizer treatments does your department perform per month?
We usually do 2,000 or more.
What about incentive spirometer?
About 1,200, 1,500, depends on the month. You know, we do every one of the post-ops regardless of whatever kind of surgery they're having.
Okay. How many treatments are therapists expected to do per shift?
Depending on where they're working, it's like 20 to 45. ICU therapists don't have as big a load because, you know, we want them to be available in case they got to go run and bag somebody.
Okay. How is it possible for one therapist to do 45 treatments in 12 hours?
Well, that's not a 12-hour shift. That's an 8-hour shift. We're just not up to using 12-hour shifts. So like I said, productivity in our whole group is, yeah, we're leading in the nation.
How does a therapist get that many treatments done in 8 hours?
Oh, look, I know what you're going to get at here. A lot of folks don't think that stacking treatments works. But come on, when was the last time you ever saw somebody keel over from albuterol? Really? We have a guy who can do 6 treatments at a time. He cranks the O2 up to 10 liters, nebulizes the treatment in about 5 minutes. He's taking one off and putting the next one on. It goes right down the hall. I know the next question you're going to ask is about charting. We just use check boxes. We never have any real major problems with those treatments.
Have you ever read the journal Respiratory Care?
No.
Have you seen the AARC white paper on stacking treatments and concurrent therapy?
Yeah, I've seen it, but you know, my boss is also more concerned about how many employees we have. You just got to do what you got to do.
Well, tell me this, are your patients satisfied with your care?
I don't get any complaints.
Well, sir, you realize that no complaints doesn't mean that people are satisfied.
Yeah, whatever.
Do you survey them? Do you do any of the patient satisfaction surveys?
No.
Does the hospital perform any patient satisfaction surveys like HCAP?
Yeah, they do something like that, but there aren't any respiratory questions on it.
Well, let me ask you this. Does your staff do any disease management education?
No, we had a pulmonary rehab program for a while, but it wasn't making any money. The reimbursement on that's really awful. So we decided that we'd put our therapists back on the floor where they could be productive. And, you know, teaching patients, there's no money in that.
So when was the last time you attended a program meeting at your local community college?
Objection, lacks foundation.
Sustained.
Let me ask this. Are you on the advisory committee of your local respiratory care program?
Oh, yes.
Do you attend meetings?
Well, sometimes.
When was the last time you attended one?
It was about 3 years ago. They said they might want me to speak at graduation, so I went to the meeting. But then they found somebody else, so I kind of quit going again.
So what have you been told, what have you told the program that you're looking for in terms of students?
Oh, hard workers. I want people that are going to come in, get a decent wage, and do a decent day's work.
Well, what about therapists who might have an interest in research?
Oh, that's not important. We're just a small hospital. We don't do any research stuff. That's for like the big university places.
Okay. Do you ever read respiratory care to evaluate the current science in the profession?
I just read the useful stuff. I get some management tips from those other magazines that are out there, and they're written in plain English, the kind of stuff that I can understand. Doctors decide what we do around here. It's not the therapists.
Well, when was the last time you did a treatment on the patient floors?
Oh, wow, that was earlier this year. A couple of our therapists called in sick, and I had to go pick up like 5 treatments. It was brutal.
How do you dictate practice at your facility?
We've been using a policy and procedure manual.
And how old is that policy and procedure manual?
It was there when I started, so it's like 20 years and counting.
So how do you modify your procedure manual for emerging procedures and technologies?
Well, occasionally I read one of those advertorials that in the magazines that I get, and you know, they have good tips and things that I can implement in our policies.
Do you know what a CPG is?
You mean CPAP?
No. How about clinical practice guidelines?
Oh, yeah, I've heard of those.
Do you know that the AARC incorporates evidence-based medicine into their clinical practice guidelines?
Yeah, if you say so. I've heard about stuff like that in the New England Magazine for Medical Research.
You mean the New England Journal New England Journal of Medicine?
Maybe.
Yeah. Okay. Nothing further, Your Honor.
Ms. Milligan, your witness.
Doctors know what evidence-based medicine is, don't they?
Oh, yeah. Well, most of them.
If a nurse asks you to do a procedure in a certain way, what do you tell them?
I tell them we're doing exactly what the doctors ordered.
The hospital's happy with your performance, aren't they?
They haven't told me otherwise.
And you have an excellent relationship with nursing, right?
Oh, we sure do. Anything the nursing wants, we do for them. They love us.
Mm-hmm. And your employees love you, don't they?
Well, I can be a little hard on them sometimes, and some of them don't understand, but they know at the end of the day that I appreciate everything they do, and they keep our work and productivity up.
Doctors count on you to do the work they order. They don't need you to go around telling them what to do, do they?
Oh, no, we're not the doctors, they are.
Have you ever read anything in Respiratory Care Journal that could apply in your department?
No, probably. I dropped my AARC membership a while back, so I don't really get that. And you know that all the articles in there, they're like science-y things, and they've got statistics, and it's just not stuff that is of any use.
Well, have you broached the subject of protocols with your doctors?
Yeah, they don't want us to be practicing medicine, so we just kind of left it there.
Are you proud of your department and its productivity numbers?
Oh, absolutely. I think as I said, best in the nation.
Nothing further.
Mr. DeWitt, redirect.
Yes, Your Honor. Just really one more question. Mr. Nelson, do you know what year it is?
2014.
Oh, okay. Just checking.
Oh.
Nothing further with this witness, Your Honor.
Okay.
Mr. DeWitt, please call your next witness.
Your Honor, the state calls Angie Lutz to the stand. Could you please state your name for the record?
Angie Lutz, RRTACCS.
Angie, how many treatments do you do a day?
Well, it depends on what's ordered. It's usually around 20, but it could be as high as 40 per shift.
And how much time do you get for lunch?
I haven't had an uncovered lunch break in the last 18 months. Pretty much I go down to the vending machine, grab a Coke, snack bar, get about 5 to 10 minutes to myself, and then I'm usually called to the nursing floors.
Where do you work most of the time?
ICU and peds. I like the kids.
Do you think you have enough time to take good care of your patients?
Not really. We spend a lot of time doing unnecessary therapy. It's not even funny.
Well, tell me about that.
Well, we give albuterol to patients who don't even have adventitious lung sounds. We give breathing treatments to elderly patients who can't take it via mouthpiece, so we have to give it blow-by. We give treatments to kids who are crying and screaming, and it's via blow-by, so they're not getting anything. So basically, out of the whole day, probably 20% of the patients that I treat actually have an effect on their therapy who need it, and the rest of the time I'm basically handing out water.
You sound frustrated.
I am.
Well, have you talked to Steve about that?
Steve's basically told me that there's other departments out there I could find a job elsewhere.
Do you belong to the AARC?
Yes, I do, and I actually bring some journals to work, but I don't think anybody really reads them.
Does the hospital pay for your membership?
Steve says that joining the AARC is basically a waste of time, that they're going to fight for our profession anyway, and that why should I waste $78.50?
So that's a no. What do you think?
I'd like to practice respiratory care like it was in 1980.
Have you asked about protocols?
We actually have 2 ICU physicians and a pediatric physician who would like to do protocols, but Steve's basically told them that the staff isn't up to it.
Are they?
I'm not so sure. There's a bunch of us who would love to do it, but the rest of the staff is pretty much beaten down by the culture that Steve has cultivated over the last 20 years, so they're pretty happy just doing what the physicians order.
How's department quality measured?
Strictly in terms of productivity. Steve says we can fly under the radar as long as our productivity is greater than 120%.
Do you serve on any quality committees throughout the hospital?
I was asked by the ER manager to serve on their quality committee, and I was also asked by the patient care services director to serve on their patient satisfaction committee.
Well, obviously people in those committees recognize your worth. How have you enjoyed doing that?
I haven't.
You haven't enjoyed doing it?
Well, no, it's because I wasn't allowed to do it. Basically, I was told that instead of sitting down around a committee meeting, drinking coffee with the ER nurses, that I should be out doing treatments.
So your department's not represented on those committees?
Sort of. Steve attends them, and he basically says if it wasn't for committee meetings, he'd never get any sleep.
Objection. Your Honor, I object. That's hearsay.
Counsel.
Well, actually, it's a statement of a party opponent, Your Honor, but I'll withdraw the question.
The answer will be stricken from the record. Continue.
Let me ask you this, Angie. If you were the director of this department, what would you do?
I'd start looking for other opportunities. I would definitely start doing disease management. Even though I don't know a whole lot about it, I know it's out there. I'd work on protocols and pathways to look at decreasing readmissions. The nurse manager on 4 South actually said that our COPD readmission rate is 23%, which is not good. I would also look at implementing more protocols to reduce the unnecessary therapy that we do, and also decrease hospital length of stay so that we are improving the hospital's bottom line instead of some artificial set of numbers.
Do you think the hospital would let you do that?
I guess we won't know until someone tries, will we?
Well, why rock this boat? You know, why tilt at this particular windmill?
Because at the end of the day, I took an oath to do the patient no harm, to serve them to the best of my ability and put their needs before my needs. And that comes from giving quality care.
Your Honor, I have nothing further.
Ms. Milligan, your witness.
You don't like Steve very much, do you?
I like him as a person, but as a therapist and a manager, he's a lot to be desired.
So he hired you, didn't he?
Yes.
And he promoted you?
Yes, from night shift to day shift.
And this is how you thank him?
Sometimes the truth hurts.
How many times have you been to the medical staff committee?
None.
Yet you feel comfortable telling us you'd be able to get protocols approved.
Well, you miss 100% of the pitches you don't swing at, ma'am.
The ICU doctors you're talking about, they're hospitalists, aren't they?
Yes.
So they're hospital employees.
Sure.
And you think these hired docs would force protocols down the throats of the other doctors?
Objection, Your Honor. That calls for speculation from the witness.
Sustained. Counsel, continue.
Do you really think you could manage this department?
Yes, I do.
Steve has 20 years' experience as a manager. You honestly think you know more about this than he does?
I don't know how to answer that. I can say that when Steve gets called for a clinical question, he's calling us for the answer. You can't just manage a department on a spreadsheet alone. You actually have to know about the product you're delivering.
Nothing further.
Mr. DeWitt, redirect.
No, Your Honor. I think Ms. Lutz has testified just fine.
Thank you, Ms. Lutz. Mr. DeWitt, your next witness.
Your Honor, if it pleases the court, I would like to call the Associate Executive Director of the American Association for Respiratory Care as my expert witness. So I would call Doug Lair to the stand, please. Can you please state your name for the record?
Douglas Lair.
Tell the jury what your credentials are.
I am a proud registered respiratory therapist. I have a master's in business administration, and I'm a fellow to the AARC.
Have you reviewed the documents provided to you by the state?
I have.
And have you read the deposition testimony?
Yes, sir.
In doing so, have you formed opinions about the standard of practice at this hospital?
Yes, I've actually identified three of them, actually. Number one would be scope of practice. Number two would be state of the profession and elevating the professionalism of the staff. And number three, opportunities for growth in their department.
Tell us what your opinion is on the scope of practice.
Well, I think it's actually backward focused. Relying on productivity is only one metric that managers can use, but when you do so, you lose focus of value and how value can be added by the respiratory therapy staff. Looking at Medicare policy right now, by ignoring value, it's basically a death sentence for the department. They're underutilizing the respiratory therapist and overutilizing treatments.
What is your opinion on the practice of respiratory therapy at Our Lady of Perpetual Billing?
Well, the respiratory therapists, first and foremost, aren't given the opportunity to work under a protocol-driven system. Unfortunately, protocols are about 20 years in our rearview mirror. And the fact that Mr. Nelson hasn't adopted those protocols makes it almost impossible for them to succeed and look to the future. The respiratory therapists aren't using their training, their education, or their expertise. Clinical practice guidelines are not being used, nor is evidence-based practice and evidence-based medicine being used or delivered to patients as well.
And you said your third opinion was something about opportunities for growth at Our Lady of Perpetual Billing?
Yes, absolutely. In today's day and age, we can't live in the present. We have to look to the future. We have to look at chronic disease management, pulmonary rehabilitation, discharge planning, and yes, protocols. We have to make sure that we deliver evidence-based care, and we also need to make sure that we look at reducing hospital readmissions, especially within 30 days. We have to improve patient satisfaction. These are all things that are now important to the government, to our patients, and to our hospital administrators.
Well, how does the hospital get where you believe it needs to go?
Well, I have a few key bullet points that I'd like to touch on. Number one is I think it's important that all of their members or all of their staff in the department become AARC members. It helps show their professionalism, and it helps support legislation. I use the state of Texas as an example. They were almost delicensed in the state because of their sunset regulation. But thanks to a strong state society, support from the association, and dues-paying members, they were able to fight that off. Absolutely. Only with strong membership at the state and national level are we able to fight to save licensure like that. Number two would be to have respiratory therapists in their department get involved in supporting respiratory-related legislation. We're very excited to hear that there is legislation in Congress this year that includes respiratory therapists on telehealth and telemedicine bills, which will be an extraordinary opportunity for our profession to grow. And without those respiratory therapists advocating for that, it becomes more difficult. I won't go into much detail about this because I've already belabored it, but evidence-based medicine and evidence-based protocols, it absolutely helps patient safety and improve care. And while Mr. Nelson says that respiratory care and science and research is a little bit too science-y for his department, it helps define the profession. It helps define and grow their scope of practice. By engaging in clinical research and understanding how to read scientific evidence, it does allow you to develop those clinical practice guidelines or support with clinical practice guidelines and participate with evidence-based medicine. Last but not least, monitoring outcomes. Because quite frankly, it seems like the only outcome that Mr. Nelson is measuring is productivity. But when you fail to monitor outcomes such as value, mortality, length of stay, 30-day readmissions and the like, and especially how the respiratory therapist can impact that, you lose the opportunity to make an impression with your hospital administrators. And because of the Affordable Care Act, because of congressional legislation around that, his department could be in serious jeopardy of closing down if he continues down this path.
Mr. Lair, you have a master's in business administration. Tell me this. If a hospital bills $50 for a treatment and does 100 treatments for a single Medicare patient, do they collect $5,000 from Medicare?
Sadly, that no. I wish that were the case, but that's not.
Well, why not?
Because according to Medicare and their reimbursement policy, hospitals are reimbursed based on diagnosis-related groups. They're not reimbursed based on the number of procedures they deliver, but rather the disease process at the onset of admission. And furthermore, they're now being reimbursed and incentivized by achieving exceptional outcomes and patient satisfaction scores.
Okay. What happens if a patient, like a COPD patient, is readmitted to the hospital within 30 days?
The hospital actually loses money. They do not receive any reimbursement at all, so it's a matter of cost avoidance. In 2013, there were more than 2,000 hospitals nationwide in our country that lost a combined $300 million as a result of excessive readmissions.
Are private payers looking at these same issues?
Absolutely they are. Right now it's strictly the government, but the government historically has been trailblazers when it comes to reimbursement policy. But what we've also found out is that the commercial payers are not far behind. So what we are seeing right now with the government and predominantly the Medicare patients, it's the commercial payers and the blues that will soon to follow.
Well, tell me, what impact does the Affordable Care Act have on the scope of practice?
The Affordable Care Act per se does not have a direct impact on scope of practice. That's driven at the state level, Mr. DeWitt. But what the Affordable Care Act does do is it drives scope of practice. Departments need to start looking at untraditional roles for the respiratory therapist to work outside the traditional paradigm that we have for years and years and years. No longer are aerosol treatments and incentive spirometry and oxygen rounds going to be acceptable. It's the Affordable Care Act that's driving it. It will drive it and continue to drive it, and those hospitals that don't adopt those untraditional roles and find value in other ways could be in big trouble.
What opportunities are presented by the Affordable Care Act?
Well, first and foremost, I touched on a few of them earlier. First and foremost, I think it's the chronic disease management. We have COPD that was recently added to the hospital readmission reduction program. Hospital case managers are perfect opportunities for respiratory therapists to work in pulmonary rehab, and even to work outside the walls of the hospital to keep patients in their home. But we have an opportunity like never before to actually promote wellness and prevention, smoking cessation. For years and years and years, respiratory therapists have always treated the symptoms of lung disease. Now we have an opportunity to make a difference and prevent it.
Mr. Lair, let me just ask you this question, because I think this is sort of what you're driving at. If the profession doesn't advance, what happens?
I think we go away.
And why is that?
Hospital administrators aren't going to have a choice. They are constrained by financial restrictions within the Affordable Care Act. And if we can't define our value, if we can't show them that we are the best and most qualified people to work at the bed space to take care of patients with lung disease, they're going to find somebody else who will. Another professional, somebody else who makes less money, and we'll go away.
Mr. Lair, thank you for your testimony. Your Honor, I have nothing further for this witness.
Ms. Milligan, you may cross-examine the witness.
Mr. Lair, you'd love to see everyone be an AARC member, wouldn't you?
I sure would.
Because that would raise your revenue, wouldn't it?
Actually, we put all of our revenue dollars back into the profession to promote and develop the profession. We put it into legislation efforts to advocate for respiratory therapists and for patients. And I give you one example. The AARC has one lobbyist in Washington, D.C., and 2 additional people in our government affairs department. When you compare that to a profession like nursing, who may have 20 or 30 lobbyists working on their behalf, yeah, we could use more membership.
Okay, let's go in another direction. In your opinion, if a therapist isn't an AARC member, is he a bad therapist?
Absolutely not. I think everybody in this room probably knows of a therapist who's exceptional at what they do. They're a good therapist, and they're not an AARC member. But just because they're a good therapist doesn't mean that they can't be a great therapist. AARC membership helps and allows respiratory therapists to become not just good, but great at what they do. They get access to resources and tools to make them better therapists, to focus on patient safety and improve better patient outcomes.
Mr. Lair, do you know of a single hospital in this country that gets paid more from Medicare because the patients are happy?
Absolutely. You could go to www.cms.org or hospitalcompare.org, and you can look at your hospital, another hospital in your city, another hospital in your state or across the country, and find out how your hospital compares with patient satisfaction, how your hospital performs regarding reimbursement incentives with patient satisfaction, as well as other outcomes. So yes, there are hospitals out there that are doing well and doing good things.
Nothing further.
Thank you, Mr. Lair. Mr. DeWitt, any more witnesses?
No, Your Honor. We have. We believe that the state has met its burden of proof, and we rest.
Ms. Milligan, your first witness.
Yes, the defense calls Mr. Carl Hinkson to the stand. State your name, please.
Carl Hinkson.
And how long have you worked at the hospital?
About 14 years.
We've heard a lot of people talk about scope of practice at your hospital. What's your view of scope of practice?
I love it. I do what I'm trained to do. I come in at 7, work till 3, and I still have enough time to go out with my buddies at night.
Well, I'm not asking so much about your hours, Carl, as your responsibilities. Are you satisfied doing what therapists do there?
Sure.
Would you want to learn new stuff, like how to manage ventilators by protocol, intubate patients, do disease management, all that stuff?
Not really. I'm happy as we are. We draw the gases, and the docs give us the orders. That's worked pretty well for the last 20 years or so. I don't see why it needs to change. And I don't want some shark lawyer coming after my bass boat because I followed a protocol and someone died or accidentally put the tube down the wrong pipe. No offense, ma'am.
None taken. The Associate Executive Director of the AARC testified here today. Do you know who he is?
I'm not a member.
Why not?
Because they want you to pay dues. It's like $125 for 2 magazines, one of which is all scientific-y. I'd rather put my money in the bank.
Well, what about your state society?
That's all the muckety-mucks from the university hospital. I don't go to those meetings unless I need free CEUs. I'm not a member there either.
So, how do you find out about these CEUs or presentations?
Oh, well, Angie brings her magazines and leaves them in the report room.
Mr. Lair talked about COPD readmissions. Is your hospital working to reduce those?
Oh, we don't have anything to do with that. Case management handles all the discharge planning and education for the patient. If we get an order for therapy, we deliver the therapy. That's what we do, and it works well.
How many do you do?
On days, at least 40 a day. The more treatments I give per day, the more money the hospital makes.
What's your favorite part of the job?
My other coworkers. We're friends on and off the job. Steve frequently comes with us on Fridays when we go to the Stein House.
Well, Carl, it sounds like your department doesn't need any outside help from people like those you call the muckety-mucks. Is that right?
Right as rain.
Nothing further.
Mr. DeWitt, your witness.
Well, thank you, Your Honor. We're going to talk a little bit about value here, Carl. Tell me, how much is a pitcher of beer at the Stein House?
Why, are you thirsty? On Fridays, after 5, it's $2 off, so about $11.
How much does your hospital get paid for an inpatient nebulizer treatment?
We bill about $30 for each neb. If we put 2 drugs in it, then we get to bill double. Pretty sweet, right?
Well, perhaps you misunderstood my question. I asked you how much you got paid.
I don't know. That's for the finance people.
Let me ask you another question. How much do you get paid?
I get paid $35 an hour.
Now, isn't it funny that you know how much you get paid, but you don't know how much money the hospital gets paid for what you do?
I guess I don't need to know. If I did, Steve would have told me. He's pretty good about that.
Well, let me ask it this way. Your hospital charges insurance patients $30 for a neb treatment. If you have a patient on Medicare and they're here for a week and you do 6 nebs every day, how much will you be paid for each neb?
Steve's the manager, not me. I'm just the RT. All that finance is for the other people.
But didn't you just earlier testify that the more treatments you do, the more money the hospital makes?
Yeah, it only makes sense. 5 hamburgers at McDonald's cost more than 2, doesn't it?
Well, what if you're wrong about that?
I'm not sure what you're asking.
Well, here's another question for you. Let's say that Mr. Jones has COPD and he comes in with an exacerbation. And you treat him and you send him home on Monday and he's back on Wednesday worse than before. If he's a Medicare patient, does that have any impact on your hospital's bottom line?
Of course, we get to bill for another hospitalization. We always say that the season for wheezing is always so pleasing. Steve doesn't like paying overtime, but every now and then we get some. Full hospital beds means the hospital's making money.
And suppose you're wrong about that.
That doesn't make any sense. I've already made my analogy with the hamburgers.
Have you ever investigated how your hospital gets paid?
No, I don't need to. I get paid twice a month. I love my job. I like to take care of sick people. I can set up 6 nebs at the same time and still have time for lunch. My boss is good to me, and I think everyone in this courtroom is picking on him, and I don't think it's fair.
Nothing further, Your Honor.
Please call your next witness, Ms. Milligan. Thank you, Mr. Hinkson.
The defense calls Tom Lamphere to the stand. You're a program director at Gotham City University, right?
I am.
And how long have you been employed there?
Since 1978.
Would you consider the program at Gotham City to be a good one?
Absolutely. We're one of the most financially successful programs in the entire university. We never have a problem securing any new students, and our program is accredited by AARC.
What does that mean, accreditation and good standing?
Well, we're in good standing means that we must maintain a certain pass rate for the CRT, that's the Certified Respiratory Therapist exam. We have to have a pass rate of at least 70%, and also a job placement rate of at least 70%, and we also have to keep our attrition rate at no more than 40%.
And are you an AARC member?
Yes, I am.
Do you require membership of your Director of Clinical Education?
No.
How about your students?
No.
Well, why not?
Well, because I don't want to come across as a shill for the AARC. It's $125 is a lot of money for my DCE. He's got a lot of expenses at home, and the students, well, they got books and, they have other expenses too. It's not cheap.
That's nice of you. I'm sure they appreciate your sensitivity.
I hope so.
Does your program teach students what they need to know in order to be successful following graduation?
Yes.
And do you teach protocols in your program?
Yes, they get to go through different protocol simulations on the computer lab that we have up in the university's computer lab upstairs.
Oh, okay. Is it a requirement that they be able to progress through a protocol in order to graduate?
No.
So what you're telling me what you're teaching is over and above what they need in order to graduate?
Yes, it is.
Did you know Steve before you took your job?
Yeah, I've known Steve since we went to school together. Yeah, he's a good guy. We still get together for a few beers every now and then and talk about the old days.
Does he employ any of your students?
Yeah, he's got, eight of my graduates there right now, and some of them go way back to 1980.
Let's move on to another topic. You rotate students through Our Lady of Perpetual Billing Hospital, don't you?
Yes.
And they get a good experience there?
Yes, students have to work hard there. It teaches them discipline, a good work ethic, and it prepares them for life after graduation.
Do you work per diem at Our Lady of Perpetual Billing?
Yes.
And you enjoy the work?
Sure, it's good money. I don't get benefits, though.
So you enjoy the work, that's good. Just one more question. You're not critical of Steve's department, are you?
Oh, no.
Nothing further.
Mr. DeWitt, you may cross-examine the witness.
Thank you, Your Honor. Mr. Lamphere, do you consider the respiratory therapy program at Gotham City to be a good one?
Yes.
How many students do you take every year?
As many as we can get.
How many do you have this year?
19.
How many did you start out with?
30.
You said earlier that COARC requires an attrition rate not to exceed 40%, right?
Yes.
So if you lose 11 students out of 30, that's a attrition rate of 37% by my calculation. Does that sound about right?
I don't have a calculator. Yeah, that sounds right.
How many of your students passed their CRT examination the first time?
We have a 91% pass rate on our CRT.
Is that on the first time?
Well, no. Some of the students have to take it more than once.
And how many is more than once?
Well, 2, 3 maybe. I don't know. I guess it's at least 2 or 3 times.
Okay. How about the RRT exam? How many passed the RRT exam?
Well, a little less.
How much less?
I don't recall right off the bat.
Well, I'm holding the NBRC statistics right here, and it says your pass rate is 42%. Does that sound about right?
Maybe in a bad year, sure, but, depends on the students. Some are better than others.
What percent of your graduating students secure employment following graduation?
Well, our students do very well in the marketplace.
Obviously, you didn't understand my question. What's your placement percentage?
It was 72% last year. Again, a lot of it depends on the students. Some are better at getting jobs than others.
So the RT program at Gotham City, which you said is a good one, has an attrition rate of 37%, a pass rate on the entry-level exam of only 91%, of which takes some students 2 and 3 times, or maybe even 4 times to pass the exam, and a 42% pass rate on the RRT exam and 72% job placement. Is that correct?
Yes.
Given all that, would you encourage your child to enroll in your program?
Sure.
And is that because as faculty at Gotham City University, they get to go for free?
Objection.
Withdrawn, Your Honor. Is your compensation tied to the number that graduate?
Objection, Your Honor, that's harassment. He doesn't need to know how much he makes.
Counselor?
Well, Your Honor, I'm not asking how much he makes. I didn't ask that. I asked if his compensation was tied to the number that graduate.
Overruled. You may answer.
Yes, and our program is financially successful. My bosses are always pleased.
Do you simulate clinical problems to teach critical thinking?
Do I stimulate what?
How do you go about teaching critical thinking and clinical decision making?
Oh, you mean like the clinical simulations. We bought some of those ClinSim software and put it in the labs up in the computer lab. We just send them up there, and when the students have free time, they go up and work on their own. It works out pretty well.
You would agree with me, wouldn't you, that whether a therapist is a CRT or an RRT, they have to know how to reason through a clinical problem?
Yeah, I guess. I would hope so anyway.
So if a therapist comes into an ICU room and finds saturations in the low 80s, they would have to know how to deal with that problem. You teach that?
Yes and no. I mean, I would expect every student to know the difference between an SaO2 of 80% and a PaO2 of 80.
Do you teach patient communications?
Yeah, we have a module on that.
Do you do any role-playing?
Nah, the students don't take role-playing seriously. It doesn't replace real-life situations.
Oh, well, let me try it this way. Are you ACLS certified?
No. But I was 15 years ago.
Well, I'm not asking about 15 years ago. I'm asking about 2014. Are you ACLS certified, yes or no?
No.
Well, do you know what a megacode is?
Sure, that's where the ACLS instructors have you role play. I mean, pretend. You're in a real-life code situation. It's meant to teach you how to handle a cardiac situation and resuscitation using the strips and medications, that kind of stuff.
Do you do anything like that with your students?
No, not really. We don't have the time. Look, we teach the ABCs, airway, breathing, circulation, but we don't run through megacode simulations as part of our program. We just do the clinical simulations up in the computer lab.
Well, not to put too fine a point on this, but if we took one of your students, just pulled anyone out at random, and a couple of weeks before graduation from your program, we threw them into an ER room with an intubated patient, and there were doctors yelling at that student that the SATs were falling, would that therapist know what to do and how to handle it?
I would certainly hope so.
But you don't know, do you?
Oh, it would depend on the student, and some are better than others. I've said that.
Would you agree with me that anyone who could not work through a situation like that should not be passing your program?
No. Look, there's nothing in the accreditation or the licensure statute that says that we have to do that, and it would have a devastating effect on our graduation rates if we were to employ such a standard.
Which might have a devastating effect on your salary.
Objection. Harassing.
Withdrawn. You said earlier in your sworn testimony that you're an AARC member, correct?
Yes.
Do you find value in your AARC membership?
Yes. It represents to the world that I'm a true professional and someone dedicated to my craft.
Are you a member of the education section?
No.
You also mentioned earlier that you didn't push AARC membership on your director of clinical education because I think you said $125 was a lot of money. Is that correct?
That's what I said.
But if you're a dues-paying AARC member, wouldn't you know that membership's not $125, it's $78.50? Answer the question, please.
Well, I guess.
What do you mean, I guess?
Well, what I mean is I just always forward the renewal form to accounts payable when it comes in the mail. You know, they paid my membership for me.
So you had no idea membership was only $78.50?
No.
Your Honor, may I approach?
Absolutely.
Your Honor, I'm handing to the court and representing to the court the following membership report subpoenaed from the American Association of Respiratory Care. Would like to introduce that into evidence.
Mr. DeWitt, this looks like a copy of Mr. Lamphere's membership record, to which he has already said he is a member. Ms. Milligan, do you have any objections to this evidence?
No, Your Honor. I've seen the record. It states exactly what he's already testified to, that he's a dues-paying member of the AARC.
I'll accept the evidence.
Thank you, Your Honor. Now, Mr. Lamphere, you had indicated you're a member of the AARC, but the record held by the judge there shows that your membership lapsed from 2007 to 2009 and also from 1999 to 2003. If your employer pays your dues, why weren't you a member during those years?
Money was tight for the university at that time, and you know, I tried to get the membership paid, but they wouldn't pass it through.
But if the AARC membership is a good value, which is something you've already testified to, Mr. Lamphere, and it's representative that you're a true professional and dedicated to your craft, your words, not mine, then why didn't you pay your membership dues out of your own pocket? Mr. Lamphere, your answer, please.
You want answers.
I want the truth.
You can't handle the truth. Son, what I do each and every day is not easy. I give degrees to 50 or more students every year. I make money from our university, and I help find jobs for people who are out cutting grass and washing dishes 2 years before they came to my program. I send students to Steve's program and to his hospital because he teaches them life lessons. He shows them how to be hard workers, you know, teaches them a thing or two about productivity. Do I care that all they do is stack treatments? No, of course not.
Let's have a
And you, Mr. Lair, Mr. High and Mighty. What does an AARC membership really do? What, 2 lousy magazines a year? Discounts on your already overpriced meetings? Disease management? Are you really kidding me? I don't have any room in my program to add more content. And if you really want students to have a job, why don't you hire them? And what am I supposed to do? Put a gun to the hiring manager's head and say, hire my students? And you, Mrs. Lutz, really? Get a clue. Get realistic. This is not the profession it was 20 years ago.
Your Honor, if it pleases the court, I suggest we move to closing arguments. The witness has rights. Sherry?
Ms. Milligan, the floor is yours. Thank you, Mr. Lamphere.
Your Honor, what the state says just isn't true. Not every hospital's the Mayo Clinic or the Cleveland Clinic. You can't judge a 200-bed hospital by 700-bed hospital standards. You can't expect a staff therapist in Peoria to do what they're doing at the Mayo Clinic. It just isn't possible. Respiratory care is a big tent. If you want to do protocols and manage ventilators, go somewhere where they do that. Vote with your feet. Don't come here to Our Lady of Perpetual Billing and tell Steve how to do his job. You don't know what kind of hassles he faces on any given day. He has administrators to report to. He has reports to file. He has to monitor productivity. The pressure's always on. Steve is the kind of guy you could sit down and have a beer with. Great guy. He does that with his staff now and then. He's approachable. He feels responsible for each and every one of them. He loves these guys. Is he letting the AARC write his policy manual? No. His manual's just fine. It doesn't have AARC guidelines in it because he runs his department, not a bunch of folks from different states. Could he do more? Sure. The hospital's making money, though. His jobs and the jobs of his people are secure. He's right on track. Don't be confused. Don't convict Steve for doing the job the way he sees it should be done.
Mr. DeWitt, you have the floor.
Thank you, Your Honor. May it please the court. I have the burden of proof. I want you to convict the profession of negligence. Not in the classic sense of having failed to meet the standard of care, but rather for failing to advance the standards of practice of the profession. The profession has become too complacent. Managers are more concerned with keeping their jobs than they are with doing their jobs. The job of the manager is to lead and to do the right thing and to do it right. Managers have failed the profession. You should convict them for becoming too comfortable. You must also convict the Carls of the profession. If you don't know what value you add to your hospital, if it's only defined by your paycheck, then you're working your way out of a job. You must likewise convict the Tom Lampheres of the profession. They are content to churn out graduate after graduate with no thought to whether they are actually advancing the profession. The hour is late. There are others who are willing and eager to take jobs away from respiratory therapists. Do you dare let them? After reviewing the evidence, I will ask you to convict the profession. I want you to vote to convict so that it can be better. I'm going to take you the long way to show you that. The profession of respiratory care stands at a crossroads. One path is the easy one. It's the way things have always been done. Doctors issue orders, therapists follow them, and nothing changes. Managers face few new or challenging problems in such an environment, and educators don't have a very steep learning curve either. It's comfortable. Close the office door, Steve. Take a nap. The other path is the far more difficult one. It's the path of science-based therapy. It demands a different therapist, one carved out of scientific knowledge. The therapist who is not interested in doing 40 nebulizers in an 8-hour shift. The therapist who is interested in preventing COPD. Delivering high-quality critical care services. This therapist doesn't smoke, encourages smoking cessation, and teaches it to his patients not because he can bill for it, but because it's the right thing to do, and he knows the payoff is in the back end. These therapists don't just know protocols, they invented them. And clinical practice guidelines, they invented them too. They contributed to them, and they're constantly perfecting them. These therapists are better educated, better motivated, and better paid than their technician counterparts because they deliver value. These therapists present problems for their managers, though, because they're always pushing the boundaries. They're always asking questions. Not why, but why not? They stay current in the field. And the manager who doesn't stay current in the field soon realizes he is no longer leading the parade. He is watching the parade from the unemployment line. And the educator, she has the same problem. She has to be better than the new breed of therapists because she's teaching them. She has to make herself valuable as a resource to the hospital, not for the cheap labor pool she can provide, but because she can help reduce those never events. She can provide school-trained therapists who know the difference. She's the belt to the manager's suspenders. The Eleanor Roosevelt said that her job was to comfort the afflicted and afflict the comfortable. So my job here today is to inflict on the comfortable the worry that comes with being outdated and largely irrelevant. Remember the taunt from the movie Home Alone? Have you had enough, or are you thirsty for more? Well, are you thirsty for more? Zig Ziglar, the famous salesman, used to say that you can have everything in life you want as long as you help enough other people get what they want. You chose this profession. It did not choose you. Do you want to go backwards, or do you want to move forwards? Can you handle the truth? Because the path forward will test your resolve. You will meet with resistance. You'll have false starts. You'll win skirmishes and you'll lose battles. You may have to change jobs. You may have to go somewhere else to be the therapist you are called to be. But at the end of the career, when you look back, you will not remember the occasional failure that you had. because all of your successes will never let you forget them. Teddy Roosevelt, in his great speech at the Sorbonne called The Citizenship in a Republic, said this: "It is not the critic who counts, not the man who points out how the strong man stumbles, or where the doer of deeds could have done them better. The credit belongs to the man who is actually in the arena, whose face is marred by the dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error or shortcoming. Who does actually strive to do the deeds, who knows great enthusiasms, the great devotions, who spends himself in a worthy cause, who at the best in the end knows the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place will never be with those cold and timid souls who know neither victory and defeat." So where will you be? Will you be with the victors, or will you be with the cold and timid souls who know neither victory and defeat? The path that Artie and Carl and Tom would lead us down is that path. So you want to hear the truth? This is the truth. What the human mind can conceive and believe it can achieve. We are not in control of our results. We are in control of our efforts. We're in control of that which is within our own power. You want to know what's within your power? Your attitude is fully within your power. Viktor Frankl said that the last of a man's freedoms is his ability to choose his reaction to a given situation. Your effort is fully within your power. Your tenacity is fully within your power. The success and preservation of this profession is within your power. It is your duty to those who have gone before you and laid the groundwork for what you do. You owe them a duty to protect it. You will face adversity. You will make mistakes. That's why they put erasers on the end of pencils, ladies and gentlemen. You will have regrets. You'll face problems. When you do, you break them down. You attack problems the same way you eat an elephant. How do you eat an elephant? One bite at a time. When someone asks you what you do, you won't tell them, "Well, I'm a snot jockey." You won't say, "I'm the king of mucus at my hospital." You won't even say, "Well, I work at the hospital." Here's what you'll say. You'll say, "I make people better. I give smiles to the elderly. I make runs to the ER to intubate the patient with a gunshot wound. I hold a nebulizer for a child who cannot breathe because of asthma. I hold the hand of a dying man whose years of smoking have caught up with him. I push down on the chest of the cardiac arrest victim and urge him back to life with the combination of hard work, clinical knowledge, drug sweat, and prayer. I monitor life support equipment. I have my ACLS credentials because sometimes in my hospital, I am 911. I work in a place where patients have diseases that can kill me, and I face that threat willingly every day because there is no reward without risk, and as a scientist, I manage that risk. I make life and death decisions every day. I calculate drug dosages. I do cardiac outputs, and most importantly, I listen to people. I resuscitate babies born with meconium in their lungs. I take 2 minutes to myself to brush the tears away after we lose a 16-year-old girl in the ER before my pager sends me off to yet another emergency. I deal with bodily secretions from every orifice, and I'm the extra set of hands that the nurses can't live without. Not because I'm a warm body, but because they care, and I know it. I make scared patients laugh, and I make pathogens cower. I put up with irate doctors, irate family members, irate patients, temperamental bosses. There are never enough ink pens or 15-millimeter adapters, and half the time the darn tubing doesn't fit. Equipment sometimes doesn't work, and I'm the person who can fix any damn thing in the hospital with enough 15-millimeter adapters and adhesive tape. And you can count on the fact that at the moment I need it most, somebody else has my stethoscope. I replace empty oxygen cylinders. I put up with Sidex fumes, elevators that are too small for patient beds, adhesive tape that isn't, gloves that don't fit, bad coffee, pagers that go off at lunch, and half-eaten meals in the cafeteria. I have to document everything I do. I get called in for in-service education on my days off. I get slapped. I get kicked. Sometimes I get punched. I get coughed on, pooped on, sneezed on, bled on, spit on, puked on, and frequently have people show me what they coughed up after their last treatment as if it was a great work of art. I see the horrible reality that is death and dying, and no, I would not trade places with any other professional for all the gold in Fort Knox because I love what I do. I stay for that second 8-hour shift to cover for a sick colleague because my patients matter to me and somebody has to do it. I spend more waking hours with sick people than I do my own family. I get called in when there's an emergency, sometimes at 3 a.m. I see the old life leave this world and I see new life come into it. It's the profession I chose. It's my choice. I save lives and I alleviate suffering every day. And you want to know what I make? Here's what I make. I make a difference. This is your profession. You have just proved to me with that applause that the profession has changed today. Are you with me? If you are, vote to convict and set a course for a new profession. A new set of challenges, a new tomorrow that is bright and good and fulfilling. Because you will be able to say that you were here the day the profession changed and charted a new course. If you're with me, stand up and be counted. Not just here today, but when you go home. This is your profession, your life. You owe that to yourself. Thank you and have a great trip back. Be safe. I love y'all.